Thank you very much for the introduction and for inviting me on this talk. It seems everyone's really interested to hear about antimicrobial resistance. I just want to say that I'm starting with the real basics. I'm doing a general overview from the national perspective. So you won't even hear me say one bug's name or even one drug's name in this. I'm just starting off with the platform, and if there's any presentations or lectures that will happen after that, it will just grow on that. But here you can see what the department is doing and how we're trying to implement this program. Next slide. Okay, so I thought let's start off with lots of reading. I hope everyone has their coffee and their glasses with them. Actually, I'm just joking. There's a lot of key facts here, and somebody else wrote them down for me, which is fantastic, but I haven't even yet read them. I want to go in and actually discuss what it means to us. So a study was done in the UK. They funded a study to see what is the impact of antimicrobial resistance. Is it anything we should be worried about? What's happening with it? Who cares? Just make some more antibiotics. You know, what's the big issue? But what they found is that there's quite a lot of deaths happening in AMR in the low and middle income countries. So AMR is of particular importance to South Africa and the rest of Africa as well. We see also that the use of antimicrobials increase in low and middle income countries, because these are the countries that have the higher burdens of communicable diseases. We also find that livestock production falls in low and middle income countries, especially when you decrease the use of antibiotics. We are going to be spending a lot of money on antibiotics, and the implications of antimicrobial resistance if we don't get this under control. And because it's going to occur more in the low and middle income countries, you're going to be spending more money that we could be using in other areas. And what they found is that extrapolating some data, they said in by 2050, there's going to be 10 million deaths each year from AMR. So this is a big number. I really can't comprehend it myself, but this is a nice way to think about it. So the other day I had a bit of an infection in my finger. I went and got some antibiotics, and now my finger is feeling fantastic and I can squeeze it. It was almost double the size it was now. But maybe for myself in 20 years time, what happens if I got septic and I went to the hospital and they couldn't do anything? They couldn't even operate on me because there's no antibiotics to work. The person next to me who needed to have chemotherapy treatment, she couldn't get her chemotherapy treatment because there's no antibiotics. So what does antimicrobial resistance mean for you? So when you have an elderly person in the next 20, 30, 50 years, and there's no antibiotics for you or your children or your grandchildren, I don't know if that has more of an impact for you, because these numbers are very impressive, and I'm sure they did a lot of smart science to get there. But if you really bring it home, then it becomes more critical. So when we say antimicrobial resistance, we don't say humans and drugs, we say the One Health approach. So what that means is we have obviously the hospital that has sewage water containing lots of metabolites and raw antibiotics. We have the community where you go to your clinic and you get some antibiotics, and maybe you just chuck it down the toilet because you don't feel like taking them anymore. Obviously, they give antibiotics to cattle. In South Africa, we don't have a lot of antibiotics in our plant and fish sectors. Pharmacy industry, maybe antibiotics get thrown into the environment. Also know that urine sewage is also used in the environment as manure. So at the end of the day, antimicrobial resistance is all around us. If anyone's interested in hearing about the colistin story with pigs and the mutated gene moving from pigs to humans and making us all resistant to colistin, especially the pharmacists in the audience, please send me a message. I'll send you an interesting paper our chairperson wrote. So basically, it's all around us. So Now, what is South Africa going to do about it? So we have a little house here. We call it our strategy house, and this is how we're going to go about our plans for antimicrobial resistance. So number one is we've got antimicrobial governance. I'm going to go into that quite a lot of detail just now. Then we have a number of strategic objectives. So these are the pillars holding up our AMR governance. So there's diagnostic stewardship, enhancing surveillance. This is an antimicrobial usage as well as antimicrobial resistance, antimicrobial stewardship, and the prevention of AMR, which includes IPC and vaccination. I think we're all very aware of prevention now post-COVID. Then we've got some enablers, such as our health system strengthening, research, education and communication that are supporting these pillars. And this whole structure is sitting here for the end goal of the rational antimicrobial use to improve patient outcomes. Like, I'm super happy the antibiotic worked on my finger, for example. So now I was talking about governance. So at the national level, we have the Ministerial Advisory Committee on Antimicrobial Resistance. And on the one side here, we have Prof. Mark Mendelson, our esteemed chairperson. He is a human infectious disease specialist sitting in Cape Town. Then on the other side, we have our esteemed Professor Maurits van Vuuren. He's our vice chair, and he is a veterinarian specializing, I think he did a specialty in microbiology. So our committee consists of regulatory representation, such as SAHPRA, Act 36 at the Department of Agriculture, obviously the Department of Health, where we have AMD, where I am from, which is the drug aspect, food control. Then we have clinicians, family doctors, pharmacists, and microbiologists. So this is the human health side of things. We have veterinarians, and this is a completely new world for all of us. I'm assuming we're all human health practitioners on this call. So there are veterinarians for small animals and feed animals such as your cattle and your pigs. You get microbiologist veterinarians. It's a whole new world out there. Then we have laboratories on board, the NHLS and NICD, the National Institute of Communicable Diseases. We also have SASCOM on board, so that's the Society of Clinical Microbiologists. We also have representation on the committee from our Department of Agriculture, Land, Reform and Rural Development, the previous Department of Agriculture, Forestry and Fisheries. We also recently have a representative from our Department of Forestry, Fisheries and Environment. He's an environment chap. Then we also engage with the research councils, such as your Medical Research Council and your Water Research Council. And we also engage with various societies. For example, recently we engaged with HASA, which is our Hospital Association. There's also a number of people that we engage with as need be, where if the committee decides that there's a topic that we really need to discuss or bring on board, we will invite those people. It's really an international, interdepartmental grouping of people. So if we're supporting the MAC, so the MAC is the executive committee. They make all the profound decisions, and they are they talk to them, they recommend certain things to the minister, but the worker bees are our technical working groups. So our education technical working group has co-chairperson of Professor Andrew Whitelaw and Dr. Vashni Governor. So Professor Whitelaw is a human pathologist or microbiologist, and Dr. Vashni is a veterinarian. They are involved in developing online education. We've got a module we've developed through the Knowledge Hub. We are currently busy developing other basic level modules for the use of antimicrobials, infection control, and diagnosis and surveillance. So you can see we're following our pillars of our strategy. And as we develop these education modules, we also we have follow-up plans after this as well to get more in depth. On the other hand, we're also involved in the professional training of healthcare professionals. Now, I am talking about your vets, your nurses, human health, animal health. Probably we might go into environmental health. That is a very new area for us, so we're still investigating what we're doing. So currently where we're at is we're looking at the undergraduate programs, and we're looking at the curriculum review. We're engaging with Pharmacy Council, Nursing Council, Veterinary Council, and the HPCSA to see where everyone's at and what needs to be updated. So this is a very, very busy group of people. Our next technical working group, this is our biggest technical working group, and poor Dr. Govind over here has to carry quite a load. So what they've done is they've broken it up into the different sectors. So we take a look at antimicrobial use and antimicrobial resistance in humans, also antimicrobial use and AMR in animals, and currently we're exploring AMR in the environment. This is a very new area for us, so we're still feeling our way. Dr. Govind is a microbiologist for human health. So what we've achieved so far in this area is we've developed a memorandum of understanding between the NICD as well as private laboratories to share data so that we can take a look from a national perspective at what is happening with the bugs and the resistance. This group has also published the surveillance for antimicrobial resistance and consumption in South Africa in 2019, as well as a recent one that has come out for 2021. So these are freely available online, and you can see where we're at with AMR and AIM use in the country. So you're really learning as you're going. Now we also have an IPC technical working group. Excuse me, which is co-chaired by Professor Shaheen Mehta, where she's involved in human health IPC, and Dr. Annelies Jonker, where she's involved in animal health. She's a veterinarian. Hopefully you're seeing the theme here of human health, animal health. The committee has tried very hard to try and integrate these specialties. So currently they're busy on a project doing a national point prevalence survey for hospital-acquired infections in the country. They're engaging with our national coordinator for IPC at the department, as well as the IPC practitioners in each of the provinces. And it's going to be the first study of its kind in the country. What we're also doing is Dr. Annelies Jonker is also engaging in the animal health side of things to do the PPS for HAIs in the animal health sector. And this is the first of its kind in the world, where we will have a human health and an animal health PPS for HAIs. So looking forward to what that comes out as. Then this group also developed the national IPC guidelines just in time for COVID. There's two pictures here as well with the guidelines, and it doesn't really help to have guidelines unless you know how to implement them. So they developed an implementation plan. So I really recommend people go and take a look at these. They're very reader friendly, and the implementation plan really gives you a step-by-step mechanism for implementing your IPC. I'm a pharmacist, as you know, by profession, so IPC is a little bit out of my scope. Okay, next slide, please. Okay, so our last stewardship technical working group is co-chaired by Natalie, who's a pharmacist at UP, and Catriona, who you might guess is a vet. I asked her what's the horse's name, and she says the horse is just called Pony, and he is a blood donor. So now Pony should be famous. So stewardship technical work group is relatively new compared to the other work. I don't know, you could have emojis like that. So it is a relatively new technical working group, so they're still busy finding their way in the committee. So the projects that they've decided to focus on is in human health. the Blix introduction, so these are the new antibiotics, the new combination antibiotics, or any new original antibiotics that we don't have the mechanism of action as yet in the country for. So they get registered through SAHPRA. So we want to have a little bit of a discussion with SAHPRA to see, is there any way we can get involved with monitoring of these antibiotics and ensuring that they are only used in the appropriate manner. And then guidelines will be developed for that. There's quite a lot of regulatory issues around that, as you can imagine, and we're pretty much in discussions how to go about this, because it's obviously never been done before. The regulator and the committee are feeling their way with that. We're also interested in doing the WHO aware integration into our standard treatment guidelines and essential medicine list. For those who don't know, the standard treatment guidelines and essential medicine list is the public sector's main guidelines for health in primary healthcare, hospital level adults and pediatrics, as well as tertiary and quaternary care. So we also have guidelines for infectious diseases and the use of antimicrobials. I'll chat a little bit more about the WHO aware index later on. So Human Health is also interested in working closely with provincial AMS champions. We've got some provinces where we have AMS champions, and these people are going to be put under a lot of work. I'm not sure if they're aware of that. They're also relatively new. We're getting to grips with what we're seeing their roles and responsibilities in the provinces are being, and what they're going to be doing and implementing and reporting back. And this is the group that's going to be helping the national department to support the provinces and actual implementation of our AMS guidelines that I'll talk about just now. Now, animal health. So animal health is a little bit behind in human health in a number of things. For example, I showed you a quick slide on our antimicrobial resistance dashboard through the National Institute of Communicable Diseases, that MOU that we have. So animal doesn't have that level of surveillance in the country. They have these laboratories all around the country, and each lab keeps its own data, and there's no integration between the labs. So you don't know, you don't know what one city is looking like compared to another city, never mind another province. So you're seeing, can we integrate them? Can we even bring this data on board onto the NICD dashboard? So we're busy chatting about that at the moment. We also want to take a look at the over-the-counter product audits. This will be through Act 36. Now, this is where it really becomes interesting between human and animal health, where Act 36, as you know, the human health antibiotics are regulated through Act 101. So there's the Schedule 4, and you need a prescription, hopefully, to get an antibiotic. Now, in animals, you can get quite a few animal antibiotics just over the counter through Act 36. So now they want to do an over the counter audit to see which antibiotics are in Act 36, because this becomes important when you have antibiotics that are important. Antibiotics for animals are important in human health. For example, if you give an animal an antibiotic and it can cause a certain resistance mutation in that bug that a human antibiotic cannot work against, then it becomes important for human health. I'm talking about those animal feeds, like those big groups of animals that get lots of antibiotics, not your dogs and your cats. Then the Animal Antimicrobial Classification Index. So Catriona is very interested in this. This helps to manage the use of antibiotics according to, it's actually very similar to the WHO Aware Index. So I'll chat about that then. And then also a review of the various animal guidelines. So you have a chicken guideline here, and then you've got a cow treatment guideline there, and et cetera, et cetera. And it's all like strewn all over the country, all over the place. So we want to take a look at what's happening, what can be standardized, what can be streamlined. Basically, all of this is an audit of what is happening in the country. Okay, so that is all our technical working groups that are supporting the MAC. They do all the heavy lifting. Now, these technical working groups have many people under them who are busy working away and assisting the committee in their various projects. So now, what has the MAC, or what has AMR been up to? So in 2014, the World Health Assembly endorsed the Global Action Plan on AMR. So this is the Global Action Plan the WHO developed. And then they said that all the countries have to have their own AMR implementation plans. So South Africa was on the ball, and we developed our first one in October 2015. This was for human health only, because AMR is currently sitting under DOH, and all of us human health practitioners only really understand human health. In our AMR strategy, as I showed you earlier, was to develop a governance structure, which turned out to be our Ministerial Advisory Committee. Then thereafter, we developed an implementation plan. This is now out of date, and we're actually updating that at the moment. It's quite painful. Then we went and developed the Antimicrobial Stewardship One Health Governance Guidelines. This is going to become important later on. From there, we moved on and we developed the second version of our strategy, and we took the veterinary strategy, I think 2015 or 2017, into consideration. So this second version strategy is a grouping of the animal health and the human health. Then we went along and developed antimicrobial stewardship hospital level guidelines. We wrote up our surveillance report in November 2018. We developed all those IPC documents just in time for COVID. And then this year we did our surveillance report for the previous years. So now I have a question for everybody. But if I was to ask you now to go forth and start protecting our antimicrobials, because you've heard how important it is to protect them, not only for our patients, but for ourselves, our families, and our youngsters. Now, what would be your first thought? So because I can't chat to anybody here, I'll tell you what my first thought, if I was to ask my young and beautiful self, and my first thought would be like, just roll on the floor and cry, because where do you start? Like, this seems so big. You're now talking about animals. There was a horse. Now I have to go and look at the sewage. What are you saying? How am I supposed to protect antimicrobials? Like, what on earth? So this is one of my favorite statements, is how do you actually eat an elephant? So let's start at one bite at a time. So now this is where the committee comes in and helps you to choose the bites to eat of your elephant. So now let's start with step one. How would you, and I was told this is like a platform for pharmacists. So I just wanted to say that pharmacists are good at this. So if you're a pharmacist, really get involved here, because I'm telling you, this is one of your strengths. And if you're not a pharmacist, go and speak to your pharmacists, because this is one of their strengths. You can bring them on board and they can support you on this. For example, the secretariat for the MAC are all pharmacists. There's 3 of us. And we're running a tight ship, I think. So I would go and take a look at this guideline on the implementation of the strategy. And in this guideline, it shows you first steps. It's how to create your provincial antimicrobial stewardship committee, or if you're in a facility or in a private healthcare, it'll be how to create your antimicrobial stewardship structure. We've got it for the PAMS, we've got it for districts, we've got it for facility level. So whatever your level in the healthcare system, there are guidelines on how to do this in this book. So then you would want to identify your communication and reporting lines. This might sound kind of weird, but when you start putting things into place, you need to know who you're talking to, who's involved, what are your stakeholders, where are you going to chat about things that you need, or that you need to report to, or that you need reports from. So I just put an example of the MAC AMR reporting line. So here's the MAC. We report directly to the minister. We have a family, We've got a neighboring MAC, the National Central Medicines Committee. So these are the guys that approve the standard treatment guidelines. We try and touch base with the antimicrobial provincial committees, although this has been slacking a little bit. There's a lot of other committees that we touch base with. Then you'd want to do a situational analysis. Where are you sitting at? There we on our online document repository, you can see the national situation analysis that we did before writing our national strategy. So we did this at a national level as well, because we wanted to see where were we at, what did we need to do. So you would map your stakeholders, and this book supports you in who are your stakeholders. You'd identify what data you have and that you must go and collect it. You identify what policies you have in your facilities. Are you missing policies? Do you have all the policies? Are there any special ways you need to do things? And then you need to identify and prioritize your antimicrobial resistant interventions. So remember, you prioritize them. There's a whole science behind this. You start with the low-hanging fruit, you do little steps. It's fine if you take your time, because if you bite off more than you can chew, then the whole house of cards falls apart. So this is what I've extracted from the governance document, just so that you can see. This is everything that I've spoken about. Here's your composition of the provincial AMS committee, or if you want to go for a couple of chapters in, you can look at your district AMS committee, or even just your facility committee. Then everybody has a role and a responsibility, and that's discussed in here. So everyone comes to the table and has to be accountable for something. There has to be a reason that you are sitting around the table. Then we even give you a suggestion for reporting lines. Over here we have something interesting called the PTC. This is something that the AMD unit also has guidelines and policies on developing. So if you don't even have a PTC, we have guidelines to support you in making those PTCs. These communication reporting lines also just support the roles and responsibilities. Like if your CEO doesn't know that you're doing this, and it takes a lot of time, and he's asking, what are you doing? Then you obviously have an issue. You need to be communicating with him. It's actually recommended that he's part of the committee, just so that he can see the importance of it and support the committee with regards to time and other resources. Then you'd want to conduct a situational analysis to see where you're at, and then there's like advice and guidelines on how to go about that. And I've put a huge section here on AMR interventions. There's further examples in the book. There's one for IPC, there's one for antimicrobial stewardship, and pharmacists would definitely know about the administration of antibiotics with your correct dose, your correct duration, your correct frequency, and correctly documented. So this is written ad nauseum in this guideline. I really recommend you go and take a look at it with your highlighter. Okay, next slide. So not only is it important to put something into place, but how do you actually know it's doing anything? So you would want to monitor and evaluate what you're doing. So if you look at, this is one of the annexures or appendixes, you can see that we have, we even support you on how to do antibiotic consumption. There's something terrible called the DDDs. Please go and take a look at this section. It took me forever to write it, and there's examples of how to actually do the calculations. I even put this thing in here where you can go and do it in your own Excel document. If it frustrates you to death and you want some help on how to do it, you're welcome to contact me. Then there's like priority specimens and pathogens for surveillance. We explain why only certain pathogens are monitored at a national level. There's an audit tool for AMS practices if you want to throw a quick audit together. Some IPC and AMS interventions and definitions, although the IPC definitions you'd also find in your IPC documents, and also the national core standards for those people that are interested, which is everyone on this call. So I'm going to quickly go into one of our books. I'm just going to go a bit further into antimicrobial stewardship. And here's our antimicrobial stewardship how to do it book. It's called the Guidelines for the Prevention and Containment of Antimicrobial Resistance in South African Hospitals, because we love a long title. Just jokes. I just call it the AMS Guidelines because this is terrible. So the purpose of this is to institutionalize the prevention and containment of AMR in health facilities. So to make it part of the committee, part of the facility that you're working at. We focus in this on the IPC of HAIs in this book, because it's to do with hospitals and their spread. And we also talk about the application of antimicrobial stewardship practices at the hospital level. So the aim of this is the how-to guide. So it's like not a dummies guide, but for me it would be a dummies guide. And then the intended users are for healthcare workers in the human health sector. So your doctors, your nurses, your pharmacists, your micros, HAI practitioners, and this is what you would implement in your day-to-day activities while you're doing your AMR, AMS activities. So I've taken some sections out of the book just to show some examples. So you can see how wonderful and user-friendly it is. So here's the framework that I was talking about, the IPC and what all is discussed in the book, the AMS and what all is discussed in it. Once again, you can see we've described some structures for governance, facility level interventions, patient level, and then monitoring and evaluation on both sides, because you don't know what you're doing is working unless you're evaluating it to see something coming out of your interventions. So we love our AMS structures in hospitals, our organograms. So here we've even got an example. I've just taken the pictures out of it because they're nice, but in the book there's a lot of text if you prefer to read what to do. We also explain the roles and responsibilities, like here, the AMS team, what are they responsible for, and then who you would expect to see on here. If you want to bring somebody else on board, you must have a very clear understanding of why they're there and what their responsibility to the committee is. Hopefully you'll have a terms of reference. Then we've got this very bubbly picture here about the role of various healthcare workers. We want an interdisciplinary approach, because to be honest, it's pointless having a doctor saying, yeah, we must have IPC in the ward, but you don't listen to your HAI practitioner or your IPC practitioner, and you're not interested in what the nurses are doing. Then it really doesn't make sense, because the nurses are the ones who actually are implementing the activities on a day-to-day. And then controlling source of infection, etc., etc. A whole bunch of bubbles you can read there at your leisure. So, I'm going to move this thing. Some more things that are discussed in this book are key agenda items. So this would be your standing items on your agenda when you have your committee meetings. So you'll be discussing your surveillance of HAIs, you'll be discussing your antimicrobial resistance profiles, you'd also be discussing compliance with AMS program and interventions, as well as your indicators, like, are you winning? Do you have to go back and change something because nobody's doing it? Maybe it's too difficult, too time consuming. You need to communicate and feedback to your prescribers. So when the pharmacists are monitoring doctors' antibiotic usage, you need to go back and discuss with them their usage as well. And it'd be nice to have it in communication with your microbiologist, and you can see what is happening in your doctor's ward or your doctor's patients. You'd also need to determine your levels of in-service training needs as well. So we have a facility level intervention here, and this is mainly for public sector. I'm not sure if there's anyone from public sector here or if everyone's from private sector, but in this guideline, we obviously refer to the public sector use of the standard treatment guidelines. So I've put an example here of our standard treatment guidelines for the hospital level adults, and this is what we would recommend. If you're from a private sector, just check what guidelines are you using. Are they up to date? Is everyone conversant with them? Are they being implemented? Basically, you need to know where you're starting from and what people are doing and using. Now, I promised everyone that I'd speak to you about the AWARE index. So here it is. So this stands for access, watch, and reserve, and there's a nice little blurb here about what it all means. So the WHO has actually categorized the antibiotics in their EML according to access, watch, and reserve. So access should be your first-line treatment. So you go there and you commonly use those, such as you go ahead and you use your ampicillin. Then the watch group indicates antibiotics that you should not use as much to avoid further development of resistance. So here we have azithromycin, here you've got your cephalosporins, of note doripenem, ertapenem. The levofloxacin in the public sector is a bit of an issue because that's we would use in multiple drug resistant TB. And then in the third group, reserve, that should include the antibiotics that you only consider as last resort. So the colistin, because we know that these antibiotics, once you've used these and there's resistance to these, there's pretty much nothing left left in the box. And this is what we can, we start getting worried when you start using these. Also note that the side effect profiles also change to the negative as you go across here as well. Okay, on that scary note, let's go back and discuss some components of your AMS program. So I hope the pharmacist is here and looking at this. So we've spoken about you have your structure. So you've got your committee and all those people that we're going to have on it. Then we're going to have some facility level interventions. So I spoke briefly that in the public sector, we can say, are you using standard guidelines? And your private sector, you would do what you have to do with the guidelines you have. And then patient level interventions, what are you going to do? So this is in the hospital, remember. So first of all, does the patient actually need an antimicrobial? If yes, what is the most appropriate? For example, do you really need to use augmentin and metronidazole? Don't you have a overlapping antimicrobial profile there? Ensure the appropriate administration of the antimicrobial, like there's this terrible thing where in private, I know to keep the patient in the hospital, I think you have to keep the drugs on IV, where the patient could actually do pretty well on oral. So, and is there, you'd have to review the need for the antimicrobial on a day-by-day basis. Do they need that antibiotic every single day? Then what we would do is we would monitor and evaluate the interventions. So the book does explain, or it does have examples of some M&E that you can use for this. I'm not going to go into it now. Okay, I only have one slide for the role of pharmacists in AMS. If there's any more talks coming out and want a bigger role of pharmacists in AMS, I'm all for it. So pharmacists can take histories of patients, they can take a medication reconciliation, which is really important and really in the scope of the pharmacist, because we know how to get it out of a patient, what that little white pill is. I know sometimes I go to my pharmacist and I say, oh, I'm on this little white pill and I forgot the name, and she gets it out of me what it is. Meanwhile, I'm a pharmacist myself and I can't remember the drug name. They can assist with therapeutic drug monitoring, antimicrobial dosing and de-escalation. These are very interesting topics for pharmacists. Adverse drug events. Discontinuation of the antimicrobial therapy, that is a, if there's any doctors that have been bugged by pharmacists here. IV to oral switch, there's a lot of evidence and literature on these. So I don't think I mentioned that before, but these have been developed on evidence and best practices, and it's been adjusted for the South African environment as well. Okay, I once had a doctor ask me why pharmacists are interested in renal function. So it's great that pharmacists are taking that into consideration. Okay, I'm not going to go too much more into that. I think I'm running out of time. Next slide. Okay, now I mentioned briefly, and I'm going to talk just briefly about the training and implementation of AMS and IPC in hospitals. So I know it's wonderful, and I'm waxing lyrical about these wonderful books and documents that we have, and all these dashboards and what's and committees that we have at national level, and communication pathways. But what does it actually mean for the busy person who doesn't actually have time to sit and read and maybe understand or being able to contextualize the documentation? So that would be part of the audit. You would see the in-service, you would audit what is the need in your facility. You'd need to actually empower the people, see what is it they need assistance with. For example, even if I just read this book, I would still need assistance in implementing it or understanding how to implement certain sections. Like I wouldn't understand how to implement IPS. I would need to engage with a nurse, and I would require some training from the nurse so that I can understand the language she's using, so she and I can discuss what needs to be done, so that we're both in understanding and agreement what needs to be done. For example, the MAC AMR itself, we give each other quite a bit of training, because when the veterinarians came on board and started talking about biosafety and metaphylaxis, all of the human health people were like, what? So there was lots of conversations going on there, and the human health and the animal health people trying to understand each other. So the same goes for the doctors and the pharmacists and the nurses and the HAI and IPC practitioners, and everyone understanding their roles. So this might also be an important in-service training, like what is each person's roles and responsibilities, and that is examples and are given in these books about different healthcare workers' roles in this. And then you would want in-service IPC training, in-service AMS training, for example. You'd also investigate what other trainings you would require to become a nice cohesive team. Maybe have a little tea party. Maybe pharmacists just like tea and cookies all the time, I'm not sure. Okay, so I'm going to start wrapping up a little bit, to the relief of my voice box. So we have some highlights and lowlights that we experienced at national. So we are quite happy that we have a functional AMR with representation from human, animal, and environmental sectors. So South Africa is involved in a lot of international committees. There's the G20, we've got the GHSA, the Global Health Security Agenda, which is a lot of fun. And from them, we actually get a sense that South Africa is we're going on the right path. So we're engaging with our international counterparts, and everyone is seeing where everybody else is. And being a low middle income country, we're actually doing pretty well for ourselves. So everybody, please, we're on the right path. Also, our National Surveillance Report for 2021 is published, and we've got quite a strong human surveillance center. We just need to learn how to use it. Some of our lowlights is the impact of COVID, because unfortunately with the COVID, I know a lot of the healthcare professionals in infectious diseases and IPC were pulled from their AMS commitments into the COVID field. Same with us at National, we were pulled out, and we were actually supporting a lot of the COVID committees out there. So I know that we have to now pick up the pieces and starting up our AMS committees again. Also, there is very much a lack of capacity and resources, even at national level. This speaks a little bit to political will. Like if your CEO of your facility is not interested in implementing this thing that you want implemented, it's not going to happen. So it's same at a national and international level. So that's why when the World Health Assembly approved the Global Action Plan, it was such a winner, because that showed that international support was given to this. Now we just need national support on this, and the committee is trying to develop a budget for our department, as well as our co-departments like the DAF and whatever, on what we actually need to capacitate the implementation of AMS in the country. This cannot be underemphasized. So where are we at now, or what is coming in the future? So what are we at now? Where are we doing? So we are busy working with AMS champions in each province, because we want to capacitate the provinces, and we want to start engaging with the provinces and seeing where's everyone at. We did this, we were doing this pre-COVID, and then through the COVID thing it collapsed a little bit. But when we'd started it up, some of the provinces were really strong in some areas and the other provinces were weak in those areas, and we started seeing the provinces engaging with each other and supporting each other and giving each other learning points. We want to also talk about antimicrobial stewardship at the community or primary healthcare level. Like I was going on about the AMS at a hospital level. There was a lot of literature and evidence that we could pull to develop that document. However, there's nothing internationally about a specific guidance or implementation for AMS at a community level. So that is the next big headache or project. Then the national AMR surveillance in animals. This is going to be very interesting and challenging, and I look forward to that. And we are updating the strategies implementation plan, as I mentioned previously. Excuse me. Now, this is all available to you free of charge. We have an AMR training program. The first one is the awareness module. This one doesn't have a CPD allocated to it, but the ones following from this that we are still working on will have CPDs attached to it. You can enroll for free. This is free. Anyone can do it. Yeah, you can be a healthcare worker, an animal or human, or the environmental, or you could be the Joe off the street and do this course. You're more than welcome to do it. You can do it on your smartphone or your tablet or your computer. And if you don't like listening to the little videos that we have, it's also available. You can just read the PDFs. There are some questions that will be super easy for you guys to answer just to finish off the course. Then all the documents that I've spoken to, as well as more, are available on the Knowledge Hub's e-library at this link. Or you can just Google South African AMR, or just Google the Knowledge Hub and look for AMR and you'll find us there. Here's our picture. And any other documents that are also alluded to here, like our PTC committee guidelines and policy, it's coming to the Knowledge Hub soon. We're just updating our documentation. And then please email if you have any queries, if you want me to send you a link, or you're dying to know what else is out there, please let me know. I've taken a screenshot of what is on the Knowledge Hub. So these are all the documents that we have now. And one of them, for example, is that AMS guidelines that I was talking to you about. And that is me done. Thank you very much. Back to our conveners. Thank you.
Thank you, Ruth. That was quite insightful and empowering. Joe, would you like to continue from here?
Yes. Thank you, Ruth, for such an informative presentation. I see that we only have 2 questions on our Q&A section, but there were others on the chat box, so I'm going to try and...
I was saying add by 5 questions from me.
Oh, no, yeah. I also have a couple of them. So I think that we're going to go with the first two questions. The first one was, can anatomical differences contribute to antimicrobial resistance? So I'm not sure if, Ruth, you want to take them one by one, or should I actually read all of them? But I think you can answer that for now, because it's only 2.
Okay, so anatomical differences. So I'm not a doctor clinician, so I can't really speak to anatomical differences. But can they contribute to antimicrobial resistance? So let's go back to the fundamentals. What causes antimicrobial resistance? So the use of antimicrobials causes antimicrobial resistance. So if you have something wrong anatomically that causes you to require antimicrobials frequently, maybe if you're talking like cystic fibrosis or something, then yeah, that would, and you have to take a lot of antibiotics, and that would definitely result in antimicrobial resistance. So remember, antimicrobial resistance is caused by using antibiotics. You can mitigate the resistance by taking it appropriately for the right reason, to the right patient, the right antibiotic, etc., etc. But basically, using antibiotics results in antimicrobial resistance eventually at some point.
Yeah, I think I'll ask Dr. Haruna. Maybe you should ask your question live. Maybe Joe, you can continue with your next question. I'll see if I can get him to discuss what he means by anatomical, anatomical issues. Yeah, that maybe we can engage further with the question. Thanks. Yeah.
Okay, super. Okay, the second one, actually, I think it's broken into 4 questions. So I'll ask the first one and move to the second one. The first one is, what is the difference between IPC practitioner and an AMR practitioner? Let me just actually maybe add on, because then the person goes on and asks, why would you need to actually have an AMR committee while there's your PTC and IPC committee that are existing? Why can't we just integrate those committees?
Very interesting questions. So glad people are thinking and engaging. I'm loving it. So what is the difference between an IPC practitioner and an AMR practitioner? So an IPC practitioner, so it's a special, I think they want to create that as a speciality in the country. I don't think it is recognized as such. I'm not too up to date with that, but I don't think AMR practitioner actually exists. So what we're talking about antimicrobial stewardship is in your daily activities when engaging with antimicrobials or infectious diseases. So in your day-to-day activities, you would be applying or implementing antimicrobial stewardship practices. So there isn't really such a thing as an AMR practitioner. For example, a pharmacist would be practicing AMS when you are looking at your antibiotic and you're investigating whether this patient actually requires the antibiotic or that the antibiotic is the appropriate dose for this patient. The nurse would be doing her antimicrobial stewardship activities and implementation when she's looking at the resistance profile of the bug and at the drug and saying, yes, there is actually a bug here and it requires an antibiotic. So it's more like in your day-to-day activities. Your IPC practitioner is doing activities specific to the IPC practitioner, such as monitoring for the cleanliness. I'm actually not sure what all they do. I'm sure they check the clean. I know the one lady that I worked with, she was always ensuring that the cleanliness of the wards was up to standard, and she had different tests that she went and monitored now and again for that. Let's read the next section. Is it necessary to have a specific committee for AMR, whereas hospitals would already have a PTC and IPC committee? So that really depends on your terms of reference and the responsibility of that committee to the facility. Like in your IPC committee, is part of the role and responsibility of that to ensure antimicrobial stewardship activities are implemented, antimicrobial resistance is investigated, the policies of the hospital are ensured to make it easy for AMS activities to occur in the hospital. I know PTCs generally have a slightly different role, but you might not want to have a different committee. Maybe you'd want to have an antimicrobial stewardship technical working group that sits under your PTC or your IPC committee. You can do that as well. you would want to piggyback off your resources as well and not make extra work for people. So if you can piggyback off what you have, you just have to be very clear what the role of the people around the table are. So the PTC people, their role is not to look only at AMR. So I would recommend in this case is maybe have like a technical working group, and their role and responsibility is as described in its terms of reference. AMR could well fit into either of the two committees, no standalone committee. Yeah, so I agree with that. Cultures and sensitivities. So that is actually out of the scope of this presentation, and I'm not really a microbiologist, so I'm not comfortable talking with that. And that's my answer to that. Oh, sorry, I jumped to the next question. Sorry.
No, that's perfect. Maybe from my side, just to spice it up a bit and ask you, is antimicrobial resistance really preventable, or is it inevitable based on the fact that we have just continued use, I mean, for the rest of our lives? I'm just trying to check, best practices around reducing its incidence, and yeah, maybe you can just argue for either or.
So I read this one article, and when people go cave diving, they find these animals that are sitting in their own solitary ecosystem that has never had any impact from any water flowing into the ecosystem from outside. It's literally been its own ecosystem with no outside influences whatsoever. The air has not touched the outside, the water has not come in from the outside or gone out. And in these organisms, and they found some really weird type of little organisms in the water, and in these organisms they found genes for that could convey resistance to the antibiotics we have on hand now, like your cephalosporins, whatever. So that's a roundabout way of saying that antibiotic resistance is inevitable. And what we're doing here now is trying to put in systems to mitigate it. So yeah, let's lessen the impact and stretch them out. Also, another thing is what we try and do in ARVs is you try and stretch out and get the person to survive long enough that the next invented drug comes about, if that makes sense.
Yes.
So yeah.
No, that's cool. That's cool. Joe, you want to chip in? I have 3 more. Okay. But I think we will just continue for 5 minutes and see if we can close it. But I think there's also one more question as well.
Yeah, I'm actually about to ask that question. But I see some part of it, it's comments. So, and question from an anonymous attendee says, is the project on AMS in primary healthcare already in existence, and or is it just a document that has been developed at this point in time?
No, so we haven't started that project as yet. You can see that there's a lot of activities happening, a lot of technical working groups, a lot of projects, and there is the same secretariat for all of that. We are always having to prioritize, reprioritize our activities at the moment. We know that this is something that really has to be done, but we haven't started it as yet. Yeah, right. If there's anybody who's got any information or guidelines that they're busy developing, please share with me. I'd be super interested to see it. Thank you.
Cool. Okay. I think there's a hand by Masood. Joe, do you see it?
Yeah. Hello, good evening.
Yes, you may continue.
Good evening. Thank you very much for this great presentation. I really appreciate it. I have a question regarding the duration of treatment. What basically is determining the duration for how many days we need to continue antibiotics? For example, for pyelonephritis, if the patient responds within 48 hours after initiation of antibiotics, and once we see the culture is the appropriate antibiotics, which is sensitive, do we really need to continue for 10 days, 7 days, or 5 days? What are the evidence? Because we see in the book says 7 to 10 days. but we don't know where this 7 to 10 days is coming from, or maybe I don't know. Can you please explain more on this? This is the first question. And the second question I have is regarding if we give a higher dose, for example, for acute otitis media, we give a high dose of ceftriaxone and we give a single dose and it works well. What about other infections? Can we give with a higher dose and shorten the period of treatment? Thank you very much.
Maybe Ruth, maybe respond to whether the duration of treatment, how much of an impact it has on AMR, and then we can just discuss the clinical stuff as well. Yeah, sure.
Great, thanks for the question. So I'm not going to go into technical aspects of pyelonephritis and the treatment because I do not know the answer to that. What I can recommend is if you, assuming that you're talking with the standard treatment guidelines for the duration there, what you can do is you can request the references and the evidence from the committee. I'm assuming you're talking about adult hospital level.
Yeah, maybe my comment on this issue is that most of these treatments have been well studied, at least, you know, in some studies or randomized control studies. Not everything, but most of these treatments. That's number one. The second part is to remember that if you initiate antibiotics, most of your patients, probably more than 90%, if you have the right back, you know, the right antibiotic, we expect some clinical improvement or the lowering of the temperature, usually within 48 hours. And which is why if you give antibiotics and there is no response within 48 hours, you should be looking as to whether your diagnosis is correct, you have the right back, and you are providing the correct treatment. The third point is that for any treatment, it's important to reach, you know, the right blood levels, and that has to do as well with the half-lives of the different drugs. So that is, so you might treat for 2 days. If you stop, you might get a recurrence, for example, or actually you might even potentiate resistance because some of these drugs would have a longer tail, you know, and allow these bugs to start to replicate or multiply in the presence of antibiotics or antivirals. The last part is that every antibiotic, when you give it, you have to achieve what the MIC, the minimum inhibitory concentrations, and the different antibiotics would require a certain number of doses for you to achieve that. And if you're able to achieve that for at least a certain number of days, depending on the bug, you will get good clinical outcomes, but also minimize the occurrence of resistance. So I think there's quite a number of PK studies out there for different drugs and antibiotics, antivirals to look at. So quite a studied field in my view. In the HIV world, every single antiviral drug has been studied, you know, also with interactions with other drugs, etc. Yeah. I think, I think we have tried to respond to that question. Maybe as part of my closing question, and Joe, maybe if you have one more question, then we close. Is to say, Ruth, the community component, you know, how are we addressing it in the AMR program? I generally feel that the communities love antibiotics. My mother is one such person. Last week I visited her and she said to me, you know, this year I haven't received antibiotics. I said, why? She says, I must get them at least once a year. And I know how much pressure as well they put on health workers to get these, you know, just on the community engagement, education, and pharmacy, obviously playing a big part in this issue, because I see in the private community pharmacies, people just go there and ask for antibiotics without a proper clinical assessment, and half the time, you know, they still receive antibiotics. But yeah, you can just share around the upcoming initiatives, especially around community literacy, education, and engagement around the issue? Thanks.
Thanks for that. Yeah, so we had a bit of a lesson on pharmacokinetics and dynamics there. Thanks for that. And then also, yeah, you forgot to mention area under the curve. I think.
Oh yeah. I forgot.
Anyway, so other than that, well done.
Yeah.
So the community engagement, so that kind of sits differently than the community or primary healthcare antimicrobial stewardship guidelines. So the community engagement you're talking about is awareness, and we're fully aware of the requirements of that. And we've spoken to, it is such a complicated area, and unfortunately, it requires a lot of resources, which, as you may have picked up, we don't actually have access to. So what we're trying to do is we're trying to prioritize what we can do, and in the areas of what we can do, what is going to give you more bang for your buck? Because we have very few bucks, but we need lots of bangs. So awareness requires continual information and lots of bucks with low evidence of all the bangs. So we're trying to do what we can with what we have. Yeah, but yeah, it is a very interesting area. It's a very scary area. Something we're very aware of. Henry wants to say something? No?
Nice.
Yeah, she's jealous that I'm spending more time with the computer. Okay, yeah, so yeah, thank you for that. So we are aware of the requirement for awareness. It's actually sitting in our strategy. So if you want to call us out on that, you're welcome to. We also, we're not sitting in an ivory tower here. Maybe it looks like Department of Health sitting in an ivory tower and look, we have an important Mac that does important stuff and writes important things that get put online. But we're also very open to people who hopefully can come to us with strategies and answers. There's no need to come to us with difficult questions and why we're not doing stuff, because we're fully aware of all the problems we have. But if people would like to come to us with solutions and ideas and stuff that you find is working for you, then we would be really happy to listen to that.
All right, thank you very much. I think colleagues, this then leads us to the end of the session. Let me ask Joe to say his closing remarks, and maybe to appreciate our speaker as well. Thanks, Joe.
Thank you very much, everyone, for coming through, and thank you, Ruth, for giving us that presentation. It was still a high-level presentation. I think there's the need for a follow-up, and I'm thinking, the national surveillance report, unpacking that and taking us through to see actually the rate of resistance that we are sitting at as a country. The other thing that I actually wanted to add on with regards to, the determining when to stop antibiotics, there are biomarkers actually that are being, checked in most infections. So when an infection comes through, there's a biomarker that will pick up, and then when you use antibiotics, it drops over time. And that has been used in most infections like your lower respiratory tract infections. I think it's procalcitonin, which you actually check. So I think in looking at such studies would actually obviously help in determining, when to stop antibiotics and when to start and when not to start. So thank you very much, Ruth, and hopefully we would actually have you again for another session. But in closing, I thought I need to ask, currently, I've seen you had a couple of documents that you guys have developed in the past few years, but the dissemination of such documents to the provincial governance committees, how do you actually ensure that the governance committees like your PTCs, your IPCs in provincial level at a hospital level, they have access to such documents? Because I think it's very important for them to actually have access to such, for them to actually implement them. Thank you very much.
All right, so Ruth, maybe you will reply to Joe and Somar, say the take-home message, and we close. Thanks.
Thank you for that. So yeah, so the national, so there are communication pathways from national to provinces. So you utilize those. So for example, we've got the HOPS, the heads of pharmaceutical services. So we send out the documents, like how we would send circulars out, send it to the HOPS, to the depots, MECs if necessary. Then also we've got stakeholder databases, so we would send it out to different organizations, like some pharmacists. So I'd get the communications coming from PSSA, HASA, etc., etc. So we've got also sometimes when we used to do our road trips, as my boss would call them, and we'd engage with people at their facilities. We would ask them for their contact details, and then we would add them to our database and send it out. We also once did through the assistance of an NGO, we went and got like all the PTC details that we could in all the provinces, and we added that to our database. So we do have databases, and we do try and communicate as much as possible. Unfortunately, like my role is not, well, I was never trained in like dissemination of information type strategies, but we do try our best, and we reach out to as many societies, organizations, people on our databases, the structures that we have access to. So that's how we send the stuff out. Yeah, and through platforms like this where you so kindly invited me.
Yes, we started. Thank you.